I'm going to record from now for what it's worth. Okay, sorry about that. Good job you turned up. Orthodontic problems, we don't get many, but if they're there, put them in. Post-surgical complications, including dry socket, sinusitis, doesn't normally need antibiotics for what it's worth. Unable to reach a diagnosis. Okay, again, this is one of the lectures later on, but don't use this code if you have not done the tests on the tooth. Go back and do the tests on the teeth and try and then say you haven't got a diagnosis. So if you haven't percussed, if you haven't palpated, you haven't taken pockets, checked sensitivity or taken an x-ray and you can't reach a diagnosis, the reason you can't reach a diagnosis is because you haven't done all the tests yet. And other means it's something else. It doesn't mean you can't be bothered checking which one it is, or it's not quite one of them. Put it down as one of the codes. If you've got a necessary care patient who hasn't got a diagnosis as such, there's not got a problem. Caries without reversible pulpitis, you might use this, or periodontitis without acute pain, you would use this one as well. But other shouldn't be something that's routine. But there are patients with some other problem. TMJD, trigeminal neuralgia, whatever you think it is. If there's more than one diagnosis, use the one that you think is relevant to the treatment so that you don't get this reversible pulpitis and extirpation coming up together. Different treatments. Okay. Right, extraction, extirpation. If you're placing biodentine, call it an extirpation for the sake of this. Incision of the soft tissue for drainage. Scaling, irrigation of pockets. Whatever you do, whether you use a scaler, an ultrasonic scaler, a syringe. And if you're doing irrigating under the operculum, use the same thing. Dressing not involving the pulps or filling. Again, if you've done if the diagnosis is irreversible pulpitis or abscess, this really shouldn't be going on very often. Dressing an infected socket, Alpha-Gel, that's the thing. Lucas curette, please, as we said last week. Arrest of bleeding, re-cementing something, more likely necessary than urgent care. Removal of a loose fragment of tooth. Yeah, if that's all you've done. If you've taken out half a tooth and you can extract the other half and you've got time and it's hopeless, please do so. Desensitizing agents, yeah, sometimes that's all we can do. Stoning a tooth, urgent referral. If you've referred somebody to A&E because they've got a medical emergency, potential sepsis, serious illness, or you've referred them for oral cancer, please make sure that your service manager knows of this for follow-up to make sure that these 2-week referrals are not getting lost. Advice, if you've not given a prescription but you've given advice, you still use this code. Sometimes patient only needs advice, or that's all they're willing to accept. Other, again, if your treatment doesn't fit in any of these categories, stick it in here. If there's more than one treatment, go for the one highest up the list. So if you've done, I don't know, stoning as well as an extraction, put the extraction down. It makes it look like you're busier. Did you prescribe antibiotics? That's the next question on the drop-down list. And so most of the time, you don't need to fill this in because you didn't give antibiotics. If this is being recorded, I come across as an alcoholic, sorry. To those that have got to leave because they're about to break their fast, I hope you've had a good day fasting. I hope that you are having a meaningful month. And yeah, and if you've got to leave, if you've got questions later, please ask. If you have given antibiotics, please complete all the questions, including your reason for prescribing. If there's more than one reason, there often is, use the one nearest the top of the list. Systemic spread of infection, that's really the reason you give antibiotics. A severe swelling, so that's open to question, what is a severe swelling? It's got to be severe, but severe can mean anything to everyone. And some people have a severe swelling when they're on the phone, but when you're there, you can't see it. Severe trismus, which is similar, but we did have somebody who recently had about 5 or 6 patients on the run that had one less than 1 centimetre opening. And on a bit of questioning, they were being a bit defensive in their note keeping, which is fair enough. We do this, but hopefully we all learn from it. Other. This should be limited because antibiotics are rarely indicated without systemic spread, unless you read today's Guardian or this week's Lancet. Has anyone read that yet? Anyone seen it? It's been noted. Okay, we're talking here about the antibiotic cover for infective endocarditis, but we're not talking about antibiotics for everything else, but it is an issue. And that might be a reason you gave antibiotics. You gave them effective endocarditis prophylaxis, told them to come back an hour later. Mentoring. So, is Bola on the call? She did suggest she might be coming. Okay. If Bola isn't on the call, Bola is big on mentoring, big on clinical peer reviewing. And we at HUDC are happy to provide one-on-one mentoring. You come to us, one of us will help you. And we're happy to discuss individual cases as well. If it's one case, if it's lots of things, you've got questions, phone up, send an email, go direct to me, to Adrian, Sarah, Hummer, Lisa, Leanne, Joe, whoever it is, it'll come back to whoever's relevant. If it's urgent, if the patient is in the chair at the moment, you can call us most of the time. I'm available, Hummer's available, Adrian's available. There's a rota that's put out each month of who's available when. If you're on the midnight to 3 a.m. slot, you're on your own, mate. Thank you very much for doing it. I'm probably still up till 1, but you go easy on me. If you want real-time advice, as I said to people before, if what you want is me to come on and sound like I know what I'm talking about and to agree with you, tell me that somehow or other in code. If you're genuinely unsure, ask the question. If it's, can you tell this patient what I agree with? It's Dr. Aaron, clinical director here. Could you just confirm my diagnosis for me, please? And I will understand that you're not after a different answer, you're after the same answer. We all need to learn and improve, everyone. And we want two-way discussion. If you think I'm doing something wrong, please tell me. Tell me now if you want, but that takes guts. Fair goes to you if you do it. Otherwise, later on, whatever. The plural of anecdote is not evidence. I've had to write this a few times because I wanted to keep it reasonably polite, but please do not be the clinician who says to me something along the lines of, in my hands, the sun rises in the west. It doesn't. If all the research for everyone else shows a particular problem, a particular treatment is correct or wrong, it ought to be the same for you as well. If you've got new ideas that are great, research them, publish a paper. If you've, we hear this quite a bit from time to time, and it is something that is a bit interesting. I don't want to go into too much detail, but the dentist who insisted on calling every patient in before lunchtime because she was worried the pharmacist would shut was brilliant. And she was the one that came out with this sort of stuff. Okay, complaint handling. It fits in with note keeping. But there are multiple cases that I've had over the years where I've had complaints come in. I've got one at the moment where they're complaining about X. X was fine. I'm going to rebut that, no problem. For what it's worth, the dentist did Y wrong. I'm not intending to tell the complainant this, but I have spoken to the dentist and we'll chat a bit further when we're finished looking at it and say, you know what, with hindsight, we could have done X, Y, and Z better. But what they're being complained about was quite unreasonable, and we're going to bat it off for what it's worth. It was a case about the patient complaining that the dentist wouldn't pull out their tooth when another dentist was able to do so. Somebody's asking, Mandeep, can I copy the articles? If you send me an email or send Joe the email, yes, whatever articles it is you want, we'll send to you. Okay, back on the complaint handling issue. This is brilliant. I get complaints about me from time to time, sadly more often than I'd like. And when I get them, I am wrong. I've done something wrong. I'm an idiot. I'm stupid. I'm the lowest form of pond life. And that's what everyone tells me. However, when the complaint is about one of you guys, I come on the phone and say, here I am, clinical director. On a good day, I'll even try and put on a reasonably eloquent voice. But they think I'm important. They think I know something. And I say, yeah, you know what? My dentist did. That was really good. That was better than most of them would have done. I can't believe you're still in pain, but, we're going to sort this out. Live complaints, you've still got pain. One of us is going to see you and we're going to help you further. And that will defuse many of these complaints. And it really is so different when it's against me as against someone else. And if you can always get somebody else to take your complaints, that's brilliant. I want someone to take mine so they can come on, sound important, make out that I did something good. Be helpful. Right. We all tend to be defensive. And when we're being attacked, we've got no choice. We have to defend ourselves within an open environment. Hopefully we can say, you know what, Scott, I hold my hand up there. I'm ballsed up. I should have done differently that time, but I want to learn from it. And obviously, if we say that in front of the authorities, the GMC case of the poor young doctor who ended up getting struck off, I think she got put back on again, but she went through hell because she wrote in her, oh, not in full. I'm sure somebody can correct me on the exact case, but in part, she wrote down in her journal of reflective practice where she balls up. So moving on, case notes. We've got a couple of cases. Others present than the nurse. Right. That was actually what was written. At least ask the lady's name. Pain and broken upper left 6 patient. Tried to put super glue in the hole to help. Okay. Medical history checked. Should have used the tab. Extra or intra, all NAD, whatever. Upper left 6 or super glue. PA taken to check the depth of cavity and apical pathology. We know why you take a PA. Here's the PA. That's all right. We can see a cavity in the upper left 6 MO, close to pulp. I guess we can see an upper 8 that's an upper 9, sorry, I think. That's there. General anaesthetic, GA, grade A for their X. I think it's grade B really. It's a bit of overlap, but whatever. Deep care is close to pulp. Informed patient of high risk of RCT. Yeah. Patient consented for provisional fill or extirpation if needed. Okay, they consented for anything and everything. They weren't under general anaesthetic. They could just consented for what you were planning to do. Infiltration given, care is removed, no exposure, GIC placed. Advised to arrange definitive treatment with a dentist. Okay, fair enough. GIC, if you use good GIC, Fuji Equa, that's fairly definitive. Patient appreciative. I love it. The patient was happy when they were left. The patient was numb when they left. Okay, we have the notes that were sent to us by the call handler on this case. Patient complaining of cracked tooth for a year. They've been in pain for a year and have started to get pain at the top left. Cocodamol, 2 paracetamol taken this morning. No swelling, but throbbing pain. Throbbing pain, okay. Hole for a year, throbbing pain. Diagnosis? Pulp involvement? I think so. Medical history, no allergies, no medical condition. Well, if you've already got it there, you can be quick about your medical history, which is good. Patient not registered with a dentist. I'll come to that later. Now, what tests were not done by this dentist? Anyone want to give me an answer? Come on.
Cold spray. Cold spray.
They hadn't done percussion. They hadn't done palpation. They hadn't done pocket taps. They hadn't done endofrost cold test. They had then written down their diagnosis was uncertain. Yeah. The reason the diagnosis was uncertain is because they hadn't taken the tests. The reality was, I saw the patient 3.5 months later. Chief complaint, upper left 6, pain daily, worse with cold, hot, eating, leaning forward, throbbing for no reason, affecting sleep. 8 months of pain, he told me, taking 4 lots of paracetamol a day. Last examination 5 years ago. He can't find a dentist in the entire county he lives in, Cornwall. So he's coming to Hertfordshire for treatment. I'm not sure quite how he ended up in Hertfordshire to begin with, but he has come approximately 200 miles to see us. And that was not because he was treated well the first time. He was had 3.5 months of further pain. We were the best he could find. When I saw him, temporary filling was still in situ, so the dentist had done a good temporary filling. The nodes were normal, percussion was TTP, the 6, but not the 5 or 7. Sulcus tender by the 6, not the 5 or 7. Pocket depths were normal. Endofrost cold test, 5 and 7 positive, 6 extremely positive. Zygomatic tap was positive both sides. Might have had sinusitis as well. But my main diagnosis, irreversible pulpitis, possibly symptomatic apical periodontitis. RCT and crown, or XLA. A filling is possible, but that meant RCT and a filling, not RCT, not a filling instead of RCT. Extirpated 3 hyperemic canals. I didn't consider Biodentine. This has been there too long. Now, I didn't note the patient was appreciative. I don't know if I'm going to hell or worse still, to Wimpole Street. But the next day, the patient contacted us. This was unsolicited. This wasn't one of these where we're fishing for compliments like we do. I've had my first pain-free drink of cold water in 8 months. I'm all very happy and looking forward to the rest of treatment. I don't think he's well off, but he was paying for this treatment. He was looking forward to having root canal treatment. He's had 8 months of pain. The first 5 months we have nothing to do with. The next 3.5 months we do have something to do with. Do the proper tests, use a template to remember to do the proper tests. The diagnosis here would have been dead simple. Note keeping is about making accurate records, but primarily it is about patient care and improving patient care. It's not about just protecting ourselves. To finish with, again, apologies to those who have seen this slide before. It's a great slide, but does anyone know what this guy is being done for? It is not note keeping. It is not infection control either, because this is obviously sterile. The stone has been washer disinfected. But on the 7th of September 2011, this is a copy and paste from the GDC's charge list. You took a periapical radiograph without using a film holder or beam aiming device. Now, I'm all for RIN holders, but it really doesn't need to go that far if you don't use a RIN holder. Thank you for your attention. Thank you very much for coming. For those of you that are listening on the chat later, the first half of this talk was much better than the second half. I'm sure everyone will agree with that. Has anybody got any questions?
No.
If you have questions and wish to ask them later, please do so. I've had a few chats in the last week or two about the previous lecture, so thank you. The questions that are asked help me to learn and hopefully help improve the next lectures as well.
Hey, Scott, can I just clarify that you say we are doing the drop? It's Suraj here.
Hi, Suraj. Yep.
Just clarify, we're doing the drop-down boxes for necessary care, because I was under the impression that we weren't. Okay.
Yeah, I think so, because otherwise it looks like you're not filling it in. So if there's no diagnosis because they've not got a pain, you can either use reversible pulpitis if that's relevant, or you can just use the other diagnosis, because then it does make sense. And I mentioned that if they've got caries, for example, put down other, because they've got no pain. Their pulp is normal, their apex is normal. You're doing a filling or interim filling. Yeah, it's other.
Okay.
That is a genuine other. I've deliberately chosen not to start adding more and more diagnoses or treatments down, because we can have millions of diagnoses and millions of treatments and everyone still goes for other. Vian, I'll ask that answer the question in a moment. For treatment, again, sometimes you will be using other. It allows us to know who's not filling it in and who's filling it in, because that's useful as well. Question, management for irreversible pulpitis but with a pulp stone. Okay, so that makes it harder. I saw a patient today, I took bite wings and they had pulp stones in every pulp. Luckily, they didn't need a root treatment anyway. But you're still extirpating if necessary. So it's obviously harder to get down those canals. If you've not got loops, it's impossible. It's a good reason to buy magnified, illuminated loops. And obviously the best reason for not buying loops is really Scott doesn't pay me enough, and I apologise. But ideally, we should all be using loops. To do anything involving pulp. I find the microscope really helpful for extractions as well. But that's me being posh and spending a fortune on a microscope. If anyone who works in Rickmansworth ever wants to be shown how to use it, I'm happy to show them. You have to come in your time, but if something you want to do, there is a bit of time taken to learn it. So irreversible pulpitis, pulp stone, get them numb, go into pulp. Often the pulp stones fall out. If there's a proper pulp stone in there, it becomes a more specialised tier 2, tier 3 treatment. Does that answer your question, Vian? Yeah, okay. What is the solution if we are unable to take a tooth out, but someone else may do so? At the moment, I extirpate and refer to IMOS. Yeah. So it's always a tricky one. If we have 100 extractions in order from easy to difficult, with 1 being the easiest and 100 being the hardest, everyone should be able to do a reasonable amount. Some of us can do 60, 70, 80. There's a few guys on here that can probably get to 100. If you can only do 10 or 20, try and find a course that does more extractions. But whatever it is, there are some teeth that are more difficult to take out. If you can extirpate it and get them out of pain that way, that's fine. If you've got somebody who genuinely can't get a dentist, maybe give it a go. And if you break it, it's a posh extirpation. I did that last week. Joe, did you get hold of the guy? How is he? Okay, so I made a mistake. I took out a tooth, I snapped the thing and left the other half in there. Hope he's okay. I know Joe was going to call him as a follow-up. But yeah, referring to IMOS isn't unreasonable, but it's got to be a difficult case. If it's an easy case, but it's just difficult for you, referring it's tricky. Referring it within us, for necessary care the next time's tricky, because what happens if the next guy can't do it either? If you've got another dentist in the building with you, or another 2 dentists it's going to be soon, maybe show it to the other dentist. What do you think of this? Do you think this one you could do? Maybe, on some occasions you might find that dentist 2 could take it out if dentist 1 couldn't. It's not going to happen often, but certainly there's an option there. Referral is good. It's doing something for the patient, but do try to do the extirpation. If they've got their own dentist, let them do the referral. When patients come for necessary care, are we doing the next stage of RCT? No, we're not, Mina. We are doing extirpation, stage 1 endo. If they've still got pain, we'll do stage 1 endo again, but we're not trying to do definitive RCT. Maybe someday in the future we will, but not now. It's nowhere near something we can do. I'll share this one for you. I was recently as a volunteer for a few days at a clinic in Jerusalem, and we were seeing poor kids, teenagers, adolescents. And the patients had been treatment planned by the permanent staff, and volunteers like me were doing the simple treatment. They did not want us doing crown preps because dentist A does the crown prep, dentist B does the fit. It ain't going to work. If I do an RCT to my standard, well, mine might be good, but the next guy might not be. I might not be good enough. They get RCTs done by permanent staff or specialists. It can't be just all of us having a go and this patient's treated by this one and that one. We'll do the basics on this service, but we can't do everything for them. We'll, pull out bad teeth, fix simple fillings, give them a bit of a perio treatment. We can't, unfortunately, do everything. And sometimes it's not worth doing an extirpation if they can't find a dentist. Obviously, each case on its merits. Some people not registered with GP, can we refer to IMOS at hospital? You can't refer somebody just because they haven't got a GDP. That's not our service. You can refer a patient if it's a tier 2 case. So you can look up the tier 2 criteria. It's got to be a particularly difficult extraction, not just we haven't got time. They need 2 extractions. It's got to be the right case. And we should use our time to do urgent care, not to try and deal with other problems within the service. But again, Vian, we can discuss each case on our merits. Wisdom teeth extractions, yeah, sometimes they've got to be referred. Not every wisdom tooth, though, is tier 2. Not every wisdom tooth needs to come out. Try and get them out of pain rather than just referring them. But if it's a bog standard pericoronitis with a heavily impacted tooth that's recurrent, needs to come out, you spend 5 minutes diagnosing it, if that. You spend 5 minutes irrigating it, if that. You've got time to make that referral if they need it. But sometimes maybe take out the upper rate. Maybe that will deal with their problem. Or stone off the upper rate, take it out of occlusion. And that does take a bit more time, obviously. Brilliant. If there are any other questions?
I've got one more question, please. Yep. Hi.
Go ahead, Asma.
I just wondered if you do an extirpation and it is a tier 2, it is a difficult extraction that you can't do, and they haven't got their own dentist, and they've tried 20 different surgeries, and there's no prospect of them finding a dentist. Should you then try to refer them as well as doing the extirpation, or only
for an extraction?
Yes. If it's a difficult
you haven't really, you haven't really got, so if you've got a really curved root or something, or a medical history, you haven't really got the time to do that, because by the time you've done the extirpation, you've used up your half hour. Now, if you have got time, by all means do it. But what we want to do is focus on our job, which is urgent care. The fact there are problems in their health service with them getting further care is a different issue.
Yeah.
And, if you've got time, wonderful. Sometimes you can say, well, I can't promise you, but maybe I'll do it when I get a chance. But it isn't our priority. Our priority is deal with our issue.
Yeah. Because they often say, "Oh, if you do the extubation, what am I going to do now?" They sort of,
Absolutely.
put that on
I
you,
get
what
it.
do I do
Unfortunately,
now?
I'd love to help you, but at
Mhm.
least if I get you out of pain and put a temporary filling in, it buys you a bit of time. Children, it's a big problem. Absolutely. They don't have access to a dentist. And when we refer them, you send a referral. Joe has to deal with the referral being turned down a few days later. We're not necessarily getting anywhere. If I've got a child in my chair who can't cope with treatment, can you afford private care? Because if you can, you will get seen better that way. It's good. We've got to be honest with patients, but sometimes it's let's try and do something, but it is difficult and sometimes it's impossible. And obviously, if you spent 3 minutes and you realise this child isn't going anywhere, spend the other 27 minutes doing the referral. But if you've had to spend 25 minutes because they're late and working out what the problem is, you spent 25 minutes sorting out, you can't do a referral as well. You can't do everything. We have to accept, sorry, this is all I can do in the time I'm allotted. I would love to help you further.
Thank
Okay,
you.
wonderful.
Yeah.
Thank you very much for coming tonight. And
Thank
as I
you.
say, the next
you.
one is Thursday the 18th at 8 o'clock, acute apical abscess, including our necessary care system. So we'll talk more about that and we'll discuss more about the necessary care system. Thank you very much.
Thank
I'm
Thank you,
going to stop the
Scott.
recording.
Bye.
Thank you.